Hey, Dr. Brooks again. So I just want to kind of go over some initial ventilator settings and a brief summary at the end. So Dr. Trafficante went over the intubation protocol, the connections as well. There's been a lot of different strategies that have been discussed on the internet by different respiratory therapists, ICU doctors, emergency physicians. What we initially thought of putting all these patients on super high PEEP using the ARDSNet tables seems to actually maybe detrimental and causing them more harm than good. So using all the available information that we have now, like I said, anecdotal evidence, evidence over the past weeks and months in the ERs and ICUs, we were able to come up with a pretty evidence-based, easy to remember strategy for initial ventilator settings. Again, this is more towards the ER. During the ICU stay, the patient may need to be put on ARDS protocols because they will develop more ARDS-like picture, but we're finding most of these patients actually have relatively normal to high lung compliance, and putting them on a lot of PEEP initially is probably not the best strategy and causing more harm than good. For the initial ventilator strategies, I've made it very, very simple. You want to start the rate at 18. Again, these patients have fairly normal compliance. They can tolerate a decent amount of minute ventilation, and 18 is where we want to start. It's a good starting point. Tidal volume, 8 cc's per kg. This is ideal body weight, which is of course based on their height. And as tolerated, this can be titrated down if the pressures are too high, but like I said before, most of the patients we're going to see have fairly normal lung compliance, and they can tolerate a decent volume and keep their pressures normal. PEEP is going to start at 8. Like I said, there's no right answer for this, but we are finding that just starting everyone with very, very high PEEPs, it likely causes more harm than good, and you're also affecting their cardiac output. FiO2, very simple, start them at 100%. You can get a post-intubation ABG, make adjustments as necessary. We're going to not recommend following standard ARDS tables in the emergency department, except for some certain circumstances, if they are in fulminant ARDS, of course. But the main things that we found is to keep it simple, keep their plateau pressures less than 30, keep their driving pressure, which is plateau pressure minus PEEP, less than 15. So, for example, let's say you have them on a PEEP of 8 and you check their plateau pressure with an inspiratory hold and it's 30. Let's say that you want to try increasing their oxygenation. Maybe you want to try some recruitment strategies. You want to recruit those alveoli. You turn their PEEP up to 10 and their plateau pressure stays the same. Well, since we just said driving pressure is plateau pressure minus PEEP, if the plateau pressure doesn't increase and you increase their PEEP, you just decrease their driving pressure, which is good, and that's how you optimize the ventilator. Permissive hypercapnia, of course, but that's going to be more for patients that have more of a restrictive lung pathology. And again, these patients aren't really presenting like your typical ARDS patient, at least initially. The goal is to keep their pulse ox between 92 and 96%. These are obviously soft recommendations. There's no right answer. And 88% may be the highest that you can get them. It may be even lower, but that's what we're going to recommend. A decent amount of oxygen. Don't keep them too high because you don't want to hyperoxygenate them. If they're 100% on the monitor, you have no idea what their PaO2 is. It may be 400. Probably not, but we don't want to hurt them that way. So in summary, Dr. Trafficante talked about the intubation protocol. He talked about the medications. We're going to recommend high-dose rocuronium. He talked about the medications for induction, etomidate, and ketamine. We're going to have videos, and on the protocol, we're going to talk about where these agents are. They're going to be able to be overridden by the nurses. We talked about the location of the materials which are going to be in the decontamination room, our pre-oxygenation strategies, and just a summary of our stair-step escalation. Suspected COVID patient, very simple. Start them with a nasal cannula at 6. Try and self-prone them if they can. See if that improves their oxygen. Non-rebreather mask up to 15. Try and self-prone them. If that doesn't work, put the nasal cannula at 6 under the non-rebreather mask at 15. Self-pronem, if they're still hypoxic, you can't get them in the 90s, or you want to just increase them because they have increased work of breathing, try them on the high flow nasal cannula. We're going to recommend limiting this to 40 liters. Once you start to get to above 75% of on the high flow in terms of the FiO2, you need to start to make some decisions what you're going to do. Obviously, it depends on how they look. It's not just a number, but you can use the ROX index, which I mentioned earlier. You just take their O2 sat, divide it by the amount of oxygen they're on. That's divided by the respiratory rate. Very simple. There's online calculators, but it's very easy to do. And if that's less than 4.88, we're finding, and studies have shown that those patients are more likely to fail high flow nasal cannula and end up being intubated. So if you're on the fence, they're satting in the mid 80s, but they look kind of okay, please apply the ROX index to the high flow nasal cannula patients to determine whether or not these patients need to be intubated. So thank you again for watching these videos. Thank you for what you do. And I think that with these strategies, which of course will evolve as we find out more, we can give our COVID-19 patients here at Blake the absolute best chance. So thank you very much.